Hello and good evening to our early arriving guests. We will get started in just over 5 minutes. Give a few more minutes for people to jump on, get comfortable. So if you have to go to the restroom before we start, please do so. You will remain muted, both audio and video, throughout the webinar. Thank you, and we'll get started soon. We will start in about 2 minutes. Start in just over 2 minutes. Thank you for your patience. We look forward to getting started soon. Good evening and welcome everyone. It is 5 p.m. Pacific on the dot where I'm located. I know we have some attendees throughout the country. My name is Madison Schwartz. I'm with the Dentist Supply Company. So while we wait just a minute or so more to allow a few more people to sign into the webinar, I'm going to go over a little bit of housekeeping for this evening. If you haven't joined a GoToWebinar before, your video and microphone will be on mute. If you have questions during the presentation, please use the question feature in the chat on your control panel. I will monitor them. We will save them for the end unless they are extremely pertinent to the slide at hand. So I will interject for Dr. Cuartas if that's the case. But otherwise, thank you. Enjoy. This session will be recorded just so everyone is aware, and we will have some interesting material to go over. That said, I am honored to be partnering with Dr. Pedro Cuartas this evening, and we are excited to present what happens in the bedroom stays in the bedroom, but should it? Again, I am Madison with the Dentist Supply Company, or known as TDSC.com, and I had the pleasure of meeting Dr. Cuartas at the New Orleans Dental Conference, where I heard him educating other doctors on the importance of sleep disorder medicine and identifying it in your patients. I thought this could be really valuable. So we decided to partner up to deliver this information to you tonight. But don't take my word for it. Dr. Cuartas graduated from the LSU School of Dentistry as a general dentist and developed a passion for sleep apnea, orthodontics, implant, and cosmetic dentistry. So without further delay, I will turn it over to Dr. Pedro Cuartas. Dr. Cuartas.
All right, thank you very much, Maddie, and thank you to everybody that's out there listening. I appreciate you taking your time out on a weekday like this, so thank you very much for that. This particular topic is very near and dear to me on many personal levels that we don't have time to share tonight, but lots of personal stories with this, and I am very passionate about dental sleep medicine and also very passionate about teaching on this topic and helping other dentists succeed in what appears to be a field of dentistry that many people attempt, give it a shot, so to speak, and just seem to struggle with a little bit. So tonight, you know, there's so many questions and items to cover regarding dental sleep medicine, and so let's see here. Maddie, I lost my main screen here if you want to share it with me one more time. But there's so many topics to talk about regarding dental sleep medicine, and so as soon as I can click on here, let's see. Maddie, are you there? Can you hear me? I lost my screen for a sec.
Yeah, I can. Sorry about that.
That's okay.
Yeah. Okay. I clicked something in it.
No worries.
So I think you took over as presenter. So 1 second.
Yeah.
Can you see my screen again?
Looks like no, not yet.
Okay. Apologies to the audience. We're back. There you go. You should be able to see it now.
Let's see here. Ah, there we are. Now I got it. All right. All right, sorry about that, everybody. But like I was saying, many topics to discuss on dental sleep medicine. With time constraints, you know, we won't have that much time to talk about all of the things that there are to talk about. This maybe you can look at it somewhat as maybe an appetizer. I like to think of dental sleep medicine as a pretty in-depth, complicated dish that is got a lot of parts and components to it. So I wanted to make tonight as practical as possible. And basically go over four key points. One is really what is our role as dentists in terms of screening for sleep disordered breathing. And I'm going to reference sleep disordered breathing. Another way of saying, you can say specifically obstructive sleep apnea, so I don't want to confuse you if you hear me say sleep disordered breathing or SDB. Second one is basically just having an awareness or helping you develop an awareness for the negative health impact that these airway issues, sleep disorder breathing issues have on a person, namely your patient's health and quality of life. and very easily recognizing the signs and symptoms that you guys are actually looking at every day, just may not be recognizing it. Very briefly, we'll spend a couple minutes on effective patient communication in terms of talking about possible sleep disordered breathing with them. And then the last one, there's a lot of questions that people are always asking is how do I start in the dental sleep medicine world if I want to do screening and beyond, maybe treating it, maybe working with physicians, things like that. So we'll cover these 4 points. Some aspects we'll go through a little faster, and then some will slow down on a few of them. So we'll kind of continue on here. First and foremost, I want to put everyone at ease because I get a ton of questions from dentists that ask, are we supposed to be screening? How do we even do that? Is it allowed? Are we doing something wrong by screening? Are we stepping on toes? So to put everyone at ease, and I know many of you have not seen this because when I poll the room that I can see, the respondents here, the response here, most people have never heard of this. But almost 6 years ago to the month, the ADA adopted these guidelines specifically for dentists to help work with and in conjunction with physicians in terms of screening for sleep disordered breathing issues in our patients as part of a comprehensive medical intake, so to speak, as part of our medical history review with patients. And so not only should we be doing it, but the ADA is encouraging and strongly encouraging dentists of all sizes and types, all dentists to screen their patients, right? From specialists to general dentists and beyond. And should treatment be necessary with an oral appliance, of course, they're wanting dentists specifically to do the treatment, working in conjunction, kind of hand in hand with the medical colleagues that we have. And that's actually part of the fun of this whole thing is working with these physicians and developing these relationships is really wonderful. So please be at ease that in doing this and everything we'll be discussing is completely endorsed and encouraged actually by the ADA. So it's important. Many dentists are not aware of this, so just wanted to share that with you guys. So sleep disordered breathing, again, another name is obstructive sleep apnea is a specific version of that. Obviously, it's under-recognized, underdiagnosed, and undertreated. Don't know if you know, but about 80% in the US, 80% of people that have, let's call it obstructive sleep apnea, 80% are walking around, most of them suffering unbeknownst to them what's going on. No diagnosis, they're just overlooked, they're missed, whatever, and that is a tremendous number. And you'll see why it is such a big deal. You'll see that in just a few minutes. So health and quality of life, as dental professionals, we all work to help maintain and improve our patients' health and quality of life. It's part of what we do. And whether we're doing cosmetic work or orthodontics or something to help someone's emotional health or self-esteem, or we're doing periodontal work or whatever else it may be, we're helping someone's health. Yes, oral health, but also their systemic health, right? And so now all we're going to be doing in addition to that is helping in the sense of screening for sleep disordered breathing. And it's very simple. Basically, we're just going to identify patients at risk. We'll show you how in just a minute. And like anything else, you tell the patient, right? So if you're screening, which I imagine most of you are screening for, let's call it suspicious lesions, oral cancers type things, we know what we're kind of looking for, right? So if you know what you're looking for, you can identify those patients that are at risk. You're not necessarily diagnosing them yourself. Most general dentists will refer to an oral surgeon for an assessment. So same thing here, we're gonna learn how to identify patients at risk for the sleep disorder breathing and do the same thing we do when we find something suspicious oral cancer route. We would tell the patient, right? No one's gonna keep it a secret. Or they're going to tell the patient. So this is nothing really fancy here. It's the same thing. So what are you needing to do this entire screening process? And so it's very simple. There's an initial form that I've included here. In a few minutes, we'll review it, and you'll be able to actually see it in your on your screen. You should be able to download it or pull it from the screen, if I'm not mistaken. So we'll go over that form. But first, we'll end up reviewing some oral signs, very easy things you see every day in your practice. The patient's medical history and the patient's family medical history. So when you combine these 4 things together, it's really a slam dunk in identifying those patients that are at, I would say, pretty high risk, okay? So very simple process to do. And back to what I mentioned a minute ago, talking about oral lesions, oral cancer, or if someone has a high blood pressure, You know, when we do a blood pressure reading on someone, if it's crazy high, repeated a few times, and it's just not getting better, you know, we don't just keep quiet about it, right? We tell them, say, look, you may have an issue. I know in your medical history, there's no sign of blood pressure history for you, but you know, you may need to go see your doctor here because we can't work with you today, and you know, go get checked out. We're screening, in essence. We're not diagnosing high blood pressure. The physician's going to do that. And so in a very similar fashion, we're going to be doing this here. And my personal opinion, in, you know, for you guys who will be seeing this presentation, you know, I really feel that it becomes an ethical obligation, because when you know the information you're going to know, I don't see how we can not talk to patients about it, right? Just like the same thing with oral cancer. So that's just my thoughts on it there. If you want to bail out, you can bail out. I'm just kidding. I hope you stick around, but you'll see what I mean in a minute. You have to excuse me on this one. Forgive me. This is really not even 101. This is pre-101. But just, we don't have the time tonight to go over it. But long story short, normal breathing, person's airway is, the oral pharyngeal airway is open. Ideally, the person is breathing through their nose, ideally, and they're fine. If you go through a progression of airway collapsing a little bit, then someone is going to have the possibility of snoring. It doesn't always happen, but snoring is its own issue, but there's really no corresponding decrease in oxygen saturation in the blood, right? So there's no hypoxemias, things like that. It's its own problem for many other reasons and can be a sign of sleep apnea. But the final stage is basically where the patient will have, in essence, for sake of argument, full-on obstruction of the oral pharyngeal airway, and it doesn't matter if they can breathe through their nose or their mouth and they're sucking in air, it's hitting a roadblock. And the patient is asleep, so they don't know, they're not aware of it. If they're sleeping with someone, then the other person may recognize it and bump them and tell them to roll over or something. But that is in a nutshell from an airway perspective. Again, this is a very simple summary for the sake of time. There's a lot more to cover in this, but for tonight, just for the sake of showing you something basic for starters. Another view of the airway from a different side. Nasal airway is very important, but fundamentally the oral pharyngeal airway, that's where all the business happens. That is where all the problems occur for obstructive sleep apnea. There are other sleep disorder breathing issues. A few of them are not tied into this airway, but for the purpose of tonight, we'll be focusing on obstructive sleep apnea. So let's jump into some signs and symptoms and realizing what's the negative impact on health and quality of life. So I'm going to read through these briefly, so I apologize. I don't love reading slides. I'm going to kind of just go quickly. Obviously, you can have daytime sleepiness, loud snoring, witness episodes of people stopping breathing during the night. Many of you may have this yourself or a bed partner that has this. I mean, it's a very common thing. Abrupt awakenings with gasping, choking, dry mouth, sore throat. Morning headaches, very common. Tough time concentrating throughout the day. Mood changes, right? A lot of depression, anxiety, irritability. High blood pressure, that's a biggie. And I know in most dental practices that can be, especially in South Louisiana, high blood pressure is a very common one. So it can be a bit of a big red flag. Nighttime sweating and a decrease in sex drive. Should be another problem there. But another major issue here is not so much the signs and symptoms, but in terms of what your patients are at an increased risk of. So things like stroke and heart disease, arrhythmias, blood pressure problems, congestive heart failure, you know, these aren't little paper cuts. These are severe, life-threatening conditions, all exacerbated by these undiscovered sleep disorder breathing issues. So as a dentist, we play a really critical role in helping our patients out. Of course, they're more at risk of type 2 diabetes, obesity, gastric reflux, depression, anxiety, glaucoma. Some interesting one, maybe not for tonight, but there's really interesting ones to discuss. There's research showing Alzheimer's and dementia links in some cases, and even recently they found, especially in women, younger women, even irritable bowel syndrome. So, you know, we're thinking, what on earth does this have to do with sleep apnea? And so the research that's coming out of this is insane, because what happens really, what I tell patients when they ask how can it be linked, you know, there's no part of our body that does not depend on oxygen concentration being proper, and our body undergoing normal, routine, rhythmic sleep cycles. And if those are lacking, give it enough time, something in your body is going to show it. A lot of times it's genetics based in terms of what is in your family history, which is why family history is so important to look at. So some really interesting things here. This statistic is insane, but the average number that they're saying is, that a person's lifespan can be shortened by either directly because of the sleep apnea or as a consequence of the apnea making other medical conditions worse. Having 12 to 15 years cut off of our lifespan is pretty darn significant, right, in my opinion. So when we're looking at a person's medical history or their family medical history, these are some of the things most commonly that we're wanting to look at. I'm not going to read through them. You can read them there. But these are all major issues that should catch our eye anyway if we're treating our patients. But certainly red flags for sleep apnea. If we see this, it's definitely a red flag. This slide is one of my favorites. So it's basically just saying, okay, these are independent predictors of heart attack. All right. So if someone is overweight, there's about a 7-fold increased risk factor of predicting a heart attack for that patient. For high blood pressure, almost 8-fold increased risk factor. And smoking, which is, everyone talks about smoking, which they should, 11-fold increased risk factor in terms of predicting a heart attack. And so we know how much we do smoking cessation counseling for our patients. We talk about, all the cardiovascular conditions and problems that can arise from smoking. And yet OSA, obstructive sleep apnea at mild, 5.3. If you don't know about the AHI stuff, don't worry about that right now. That can be talked about later. But trust me, this is on the low end, in quotes, the low mild end. It is, if I could see you guys, I'd ask you what your numbers were, but like Price is Right or something. But I'm going to advance. But 11 times is smoking. So think of this. Obstructive sleep apnea as an independent predictor of heart attack is a 23-fold increase. So the person with sleep apnea that smokes, I jokingly tell doctors, yeah, tell them to treat their apnea and keep smoking. I'm kidding, of course, but as much as we harp on smoking for being bad for heart disease, mild, quote unquote, sleep apnea is twice as bad. So why aren't we talking about it more, right? It should be definitely talked about. Really brief, I'm not going to read this, but hypertension, basically, not too many years ago, it was determined that obstructive sleep apnea is an independent cause of hypertension. Not the only cause, but it is an independent cause. It's a pretty amazing thing. Roughly 8 out of 10 patients that are taking multiple medications for their blood pressure and it's not working, almost 8 out of 10, when tested, will have obstructive sleep apnea. And when treated properly, whatever that means for the patient, could be CPAP, could be a device, could be surgery, whatever it happens to be, they do better. We actually have several patients of our own that over time have been able to, working with their physician and their care, reduce their medications, which is always a win as far as side effects and everything else goes. Nobody likes to take a ton of medication. So that's a big one there. Let's see, arrhythmias, we get a ton of recommendations or referrals from cardiologists in our town. There are cases where the sleep apnea itself, if it's bad enough, can trigger arrhythmias in the heart. It can be a primary cause. If somebody already has AFib due to some other history, maybe they had a heart attack or who knows what else is going on. If they have sleep apnea now, it's going to make it way worse. And it makes treatment failure rates much higher. So an interesting number, this one is, we talk to our cardiologist friends here all the time, and they're aware of this. We see a lot of their patients. If someone's going in for a cardioversion for AFib, and they don't have their OSA diagnosed and or treated stable, the statistic is 82% recurrence of the AFib after the cardioversion. That is an insane number, right? Cardioversion can be deadly or dangerous in and of itself, not necessarily fun to deal with. That's an incredible number, right? So it's no joke. On strokes, same thing. The numbers are pretty impressive. 72% of patients with a history of stroke already have OSA. Most patients, and there's many causes for strokes, but if someone has uncontrolled sleep apnea, severe enough over so long a time, they are more apt to suffer a stroke. So identifying patients at risk in your practice, and I apologize, I'm going kind of quick. So this part I'm going to go a little faster because a lot of these red flags we're going to look at, you see every day. This is the dentistry component of things. So some of you guys have seen this before, perhaps. The anesthesiologist uses this tool a lot to see if they're going to have a very easy day or a very difficult day with their patients. So, obviously the quadrant on the upper left, that airway looks more open than the one on the bottom right. One caveat with this, nobody sleeps with their tongue sticking out. So the Friedman palate position is a little bit more accurate in that the tongue is just more relaxed. You're not really sticking it out, but it's just a gauge. We're not going to get a perio probe and measure the airway or anything like that. We're just visually, at a glance, as soon as the patient opens, you're taking your first look. It takes all of a millisecond to determine, hey, look, which one of these do they generally tend to fall in? So it's just at a glance. Narrow arches. This is a younger person. They can also, of course, have airway issues. Many of them do. It's a whole nother presentation. But narrow arches, high palatal vaults, retrognathic jaws, tissues impinging on the airway. The dolichocephalics, these guys can also have some airway issues just because of skeletal orientation. Sorry for the picture, not mine. On ortho extraction cases, in some cases, if there's extractions with retraction components, which many are, inadvertently, the soft tissue, the tongue, whatnot, can be pushed back in essence and inadvertently impinging on the person's airway. These are one of my favorites. I can almost predict just off of mandibular tori. I mean, it's one of the ones we see so often. I have it myself. Of course, I have sleep apnea. Just seeing mandibular tori, it's not 100%, but it is alone a tremendous predictor that is a big red flag in my practice anyway, when we see this. Of course, signs of wear and tear, your bruxers, which we see a ton of. Here you have maybe some acid erosion, some tori. This person I would suspect pretty highly of having sleep apnea, and just by looking at them. No, I'm not going to tell them they have it or anything like that. I don't know. But I would be a little suspect just from things I look at daily in my life here, dental-wise, right? At fractions, you guys see this, I'm sure, all the time, and all the time you guys are sealing them and filling them, and that's what we do, and adjust the occlusion to make sure nothing's going on so that they don't come back in a week or two with it popped off, after their first or second meal. But whatever we do dentally, that's great. But these guys, when we see at fractions, it's a big red flag for sleep apnea. When I see someone with say a mandibular tori, an abstraction, and they happen to have hypertension or type 2 diabetes, bells are going off in my mind left and right, okay? This is another one, scallop tongue. Probably most people, when I talk to them, they'll tell me, yeah, we noticed scallop tongue, and sometimes we used to make notes about it. We might still make some notes about it, but that's where we stop. Scallop tongue is also one of my top 3 favorites for oral signs regarding sleep disorder breathing issues. Mandibular tori be number 1, the scallop tongue probably number 2, and the abstractions would be a number 3. But all good oral signs, we see this every day. You can just think about your day today if you went to work and probably saw a ton of that. This really brief, I just like to throw in there flat plane splints or different bruxism guards, occlusal guards. They're all great. We do many of them in our practice. Just something newer that's developing is to somehow, if at all humanly possible, there's ways of ruling out sleep apnea, because one of the most common signs of an airway disturbance for someone is nocturnal bruxism. And so if we simply go and do the guard, that's good for the teeth, it's good for the wear, maybe good for the TMJ and all that kind of good stuff. But we may be just not helping the patient completely, because we may be overlooking what is considered a life-threatening condition, which is obstructive sleep apnea. Don't know if you guys know it, but a few years back, the CDC referenced or labeled obstructive sleep apnea as a life-threatening condition. So it's a serious one that we don't want to overlook, just like we don't want to overlook like oral cancer, right? So something I wanted to throw in here, when we do occlusal guards and we've ruled out any airway issues, in our practice we're using sprint array and 3D printing. I'm sure a lot of you guys are starting to do all that or have been. An incredible add-on to the practice is 3D printing. And so we may actually be considering, or at least possibly some of the guys at TDSC putting on a webinar on digital workflow from intraoral scanning, 3D printing, all these things, because there's a lot of questions out there about it, and it is an amazing add-on to any practice. So that is how we do ours once we've ruled out, in our case, any airway issues for patients. Snoring, really brief on this, just as a word of caution. If you're already treating snoring as a primary thing, that's great. There are many treatments from lasers and other procedures for snoring, snore guards, all kinds of things. My suggestion is to please be sure that you've gotten from a physician or somehow gotten a physician-ordered home sleep test to rule out either upper airway resistance syndrome or obstructive sleep apnea or complex apnea, because if someone were to be treated by you for snoring and there's no sleep test with a diagnosis of primary snoring only, and they happen to get in a car wreck, maybe kill someone, the lawyers are going to find out what's going on. The patient fell asleep at the wheel. They're going to say that they don't have sleep apnea, but they are being treated for snoring. The lawyers will come knocking on the door and say, hey, this is great, you're treating the guy for snoring. The spouse was very happy, that his snoring went away, but where's that sleep test saying that he didn't have any sleep apnea because he killed someone because he fell asleep at the wheel? Well, I don't have one. Well, you know what that means. So just to cover yourself, treating snoring alone is great. To cover yourself, it's probably low chance, but cover yourself with getting a diagnosis of primary snoring only with no hypoxemias, no apneas. It's just a safety thing for yourself. Legally want to cover yourself. So we talked about oral signs briefly. We talked about medical history and family medical history, the things that we want to look for in our patients. And the hygiene screening form is the next step. And that one, if I'm not mistaken, it should be on your screen where you can download it or basically nab it there from the screen. And the version you have does not have any of my logos. This is a form that I may have tweaked it a little bit. I got it from a group years ago, and it's good. It's a very simple thing, and you can put your logo on top if you want, but it's a very simple form. And when your patients, well, the way we do it, we give this to every new hygiene patient that comes in the office. For sake of argument, just for today, because we're not talking about children as much, let's just say every adult patient that new patient for hygiene, just for tonight's case. And they fill it out, it takes 2 seconds. And what we do is pretty much every question, with the exception of number 3, because that's not about that patient, it's about their significant other. Every other question, if any of those are checked off as yes, then in our practice, the way we do our particular workflow would be to combine that with their medical history, family medical history, and any oral signs we discover. And we usually will at that point set them up for, we'll get their level of concern. Are they concerned about something? We'll talk about that in a minute. If they're concerned, after we explain everything briefly, then they set up for a kind of a more detailed consultation with us on the sleep medicine side. So again, different workloads for different offices depending on what you're doing. But simply as a screening tool, if you don't want to do anything beyond screening, after this conversation with the patient, you can refer them out to whoever you want in your town if you're not dabbling with it at all. So, but it is something that helps us to do, I think, our obligation for patients in terms of screening them. So I think it's a very simple, very good tool to get going. Sleep testing would be the next step. The picture on the right is an older picture, but an in-lab or PSG study, as they call it, polysomnogram, still exists today, but is more far and few between. The example on the left is of a home sleep test unit. This one is in particular from Itamar. It is a disposable single-use unit. Works with people's smartphones. Great device, extremely accurate, about a 90%, 91% correlation to the in-lab study. And very comfortable, very simple. It's really a great test. Once a patient is diagnosed from a board-certified sleep physician that works with these sleep testing companies, devices, they'll give you a report. This is just one page of a sample. In our training programs, we cover this in depth. It looks very complicated. It's really not. It's actually very easy to read, but that would be for another day for sure. And once a patient is diagnosed, not by us, but by a board-certified sleep physician through a sleep test, they're going to have some treatment options. And in a nutshell, the main categories are surgery, like the one on the top right quadrant. That is the UPPP, they call it, which is uvulopalatopharyngoplasty. They remove tonsils, adenoids, uvula, some of the soft tissue, soft palate. It can work in some cases. It's just a very case-specific thing. It's not a lot of fun to undergo, but I've seen patients with it. The other surgery component is going to be the Inspire. You may have seen TV or radio commercials on it. Inspire is basically a hypoglossal nerve stimulation. It's detecting if there's proper breathing going on with the intercostal muscle activity. And if there's something wrong, it triggers the hypoglossal nerve to basically get the jaw and tongue to come forward a little bit. I like to reference it very loosely as a surgical mouthpiece, because in essence, it's what it's kind of doing. And they do a preliminary endoscopy under sedation to see the obstruction point, because just like with mouthpieces, if the obstruction point is such that the mandibular position and tongue position is irrelevant, they're not going to do this surgery on this patient, right? The reason we don't do endoscopies under sedation to see if a mouthpiece will work is because the mouthpiece is less invasive, obviously, than sedation and an endoscope. The sedation with endoscopy is much more conservative than doing a surgery and have it not work. So, but those are the surgical options. Of course, they do things like weight loss and quit smoking and all these things, quit drinking, all that stuff. The two most prevalent options, though, that I'm sure most of you guys have heard of are, of course, CPAP or auto CPAP. Or BiPAP. There's a lot of different PAP therapies, and then oral appliances just happens to be just one of many that exist. The two that I like to use in particular, one is on the left is the Somnomed Avant, and the one on the right is the Panthera DSAT device. Both are very good. I wear them myself. I also have a CPAP for my apnea. Great devices. More to talk on that later in terms of how you pick devices. There's so many questions on all this stuff. When we scan, that's not me, by the way. If you haven't seen my picture, that's not me. But basically, I think this is a Medit scanner, intraoral scanner. To get these guys, which they do fit in our case, they drop in, I'd say honestly, without exaggeration, 9 out of 10, either one will drop in without any adjustment. 1 out of 10 will have to slightly adjust it. And the major reason for that, because it used to not be that way with other devices we would use, is the intraoral scanning. I cannot stress enough. There's so many purposes and uses for it. My gosh, so these devices are so much nicer being scanned. So highly recommend intraoral scanners for anything you're doing, but certainly in the realm of dental sleep medicine, making these devices so much better. So very briefly moving along, in terms of our third topic here to talk about is in terms of effective communication with the patient. This is nothing really hard. It's actually very simple. Like anything else, just pretend you found a suspicious oral lesion and you may want to refer them to have it evaluated. So the first thing you have to do is, you have to create awareness. You can't just refer them somewhere and you're like, why are you referring me, right? You have to create awareness. In the case here, you can use a screening form. That should be a kind of a hello. We're already looking into things here. So create awareness. Let them know what's going on. Some oral signs, perhaps, that you're seeing. Maybe reference some of the medical history, some of their conditions. So you're creating an awareness of what may be happening, things that you are observing. Then you simply share some risks of, or possible risk of, if they happen to overlook these signs and symptoms, just like with an oral cancer lesion. If you choose to ignore my recommendation here, Miss So-and-so, you are at greater risk of X, Y, and Z with the oral cancer lesions. Well, same thing here. You're at greater risk of heart attack. Statistically, you're at greater risk of shortened lifespan. So you inform them that there are some risks if you do nothing. And to me, the third and most important step for anything in dentistry that we do, my favorite 4 words, does this concern you? So I don't know if you guys know of a fellow by the name of Paul Homily. Went to a course of his years ago. I believe that's where I got this. Fantastic, extremely useful. Save yourself a lot of grief, because if the patient, you ask, does this concern you? And they're like, no, not really. Look, you can set them up a free consult. You can do anything you want. They're not going to show up. They're not going to do anything. They may later when something changes in their life, but for now, they're just not concerned. But you did your due diligence. For the patient that is concerned, oh my God, yes, I am concerned about this. My husband has this, my father had this, and he died. He had a heart attack at 52. I don't want to go the same road. Now you have their attention, they're concerned. Okay, now you can either refer them to someone in your community if you don't do anything yourself, or if you're dealing with this yourself, there's steps you can follow. But that's basically the 3 components of having a conversation with a patient. It's not very hard, but it is important to have. It takes really just a few seconds. The beauty of this within the hygiene program, the hygienists are already seeing all those oral signs the medical history they should already know. It's really no extra time. I mean, it literally might add a few seconds to an appointment to get this done. And again, we're dealing with life-threatening issues. Before moving on, I do want to make a brief point. Usually when I ask in a room, you know, how many patients do you refer out on a yearly basis because of a suspected possible oral cancer lesion? And most dentists, not all, most that I talk to will average somewhere around 7. And that's not a scientific number, it's just from me asking people. Around 7 seems to be a very, very common number. For myself personally, it's about 5 or 6 a year on the high end. And we're pretty aggressively looking. Statistically, so you have a life-threatening condition like oral cancer. You have a life-threatening condition like obstructive sleep apnea. With obstructive sleep apnea, on average, conservatively, 3 out of 10 of every hygiene patient seen in a day technically will be positive for sleep apnea. So if your hygienist sees 10 people a day, 5 days a week, I mean, on average, that's going to be about 15 a week. That's almost 70 people a month that are being missed with a life-threatening condition walking in and out the office. Nearly 700 people in a year's time if you're just doing straight numbers. So you have 7 possible oral cancers screenings that get to the oral surgeon, which is wonderful, a wonderful service to these patients. But yet we're possibly missing out on 700 sleep apnea patients. That doesn't mean they're all going to get mouthpieces or treated by you or anyone else, but at least they can become aware that they do have this and perhaps treat it in some form or fashion. So think of that number for a second. 7 oral cancer possibilities, which is it's important that we're doing this for sure. Nearly 700 on sleep apnea, both life-threatening conditions. So it's something that we need to pause and think about as to why are we not screening more for sleep apnea? So remember, key point here, you're not diagnosing anyone. We're not doing that as dentists. When we say screen patients, we're talking about literally screening like we would for a blood pressure. We're not diagnosing anyone with anything. Sleep testing and screening are 2 different things. So, and that's, we can talk about sleep testing a little bit more. There's different state rules for every state. They're becoming more the same nowadays, which is much better. But screening and sleep testing are 2 different animals. So I don't want you to confuse that. When I say screen your patients for hygiene, I don't mean sleep test every patient. That's not what I mean. And looking at 80% that are undiagnosed, they're walking around out there, undiagnosed, suffering, not knowing why, dealing with other medical issues that could be helped. So, of course, we look for the CPAP intolerant patients, but that's great. But there are 80% of people walking out there, that's millions of people, undiagnosed. So we got to look for both. So summarizing this, I'm not reading through the list, but you know, long-term treatment outcome of both APAP or CPAP, continuous APAP, and oral appliance therapy, both are shown to improve quality of life, help with the heart in all aspects, even help out with early signs, decreasing early signs of atherosclerosis, helping patients that have congestive heart failure. There's so many benefits to both treatments over the long haul. So definitely worth exploring in terms of screening patients and helping patients ultimately make sure they get treated if at all possible, whether you're involved in it directly or not. But at least start with the screening process. It's extremely critical, and you'll be helping so many people. And then kind of I think right on time here, we have just about 10, 12 minutes, more or less 10 minutes. Some practical options for dental sleep medicine. Look, integrating into your practice. I have so many questions on, you know, where do we start? What do we do first? How do we do this? What do we do with medical billing? Can we get paid? You know, is this even going to work? Do mouthpieces work? How do you choose a mouthpiece? How do you adjust it? How do you test it? How do you test it after? How do you, 1,000,001 questions. And part of the process or problem with dentists is that unfortunately, we find ourselves on this little hamster wheel, and I hope you chuckle a little bit because I sometimes feel like I'm, you know, I've been like this before. The little guy in the air is kind of hilarious. But anyway, you know, sometimes as dentists, we just are in this mode, and it's hard enough to start something new. And my gosh, it's tricky. So where do you start? And what I recommend to dentists is start with training. Just start with a training course. There are many, many, many good training courses. We offer one in particular. Get training, right? Me or anyone else, but get training to start. And That alone, whether it's just to augment your screening ability or if you want to start looking into potentially treating patients, just start with some basic training. It's not military here, but start with some basic training and become familiar with this whole process, with the disease, with other issues, start exploring it, start covering some of the business aspect. In terms of business, I'll be 2 seconds on this slide. What we find in our practice is hour per hour profitability. The sleep medicine world is about 4 times, can be up to 4 times more profitable per hour than general dentistry. And that has to do a lot with overhead and things like that. But it is a tremendous, from a business perspective, tremendous difference. And for any of you guys or ladies out there who are like myself, we're struggling with a lot of back pain and chronic pain and neck issues and this and that. I'm down to I do 1 day of general dentistry, and I love general dentistry, and you can stay doing 4 days of general dentistry. I'm not saying get decrease that amount, but for me personally, I'm doing 80% of the time is my days are on the dental sleep medicine side. Tuesdays I do general dentistry. Wednesday, Thursday, Friday is sleep med, and I love it from a physical perspective. Oh my gosh, it's so kind and gentle to our bodies, and so it is really amazing. This particular slide, if you look at the top, it happens to be the title of one of our main courses that we start doctors with. Practical dental sleep medicine, the dental part, if you notice in red, is a smaller word. The reason for that is that dental sleep medicine is, in my opinion, about 10% dentistry based. In other words, you can use all of your knowledge and experience and history and education in dentistry, and it doesn't matter if you've been working 10, 20, 50 years. You will only truly be able to apply that knowledge and experience to about 10% of what dental sleep medicine entails, namely the oral appliance therapy, which is the bubble on the top right corner. And, it's a little bit into the screening because you have to see the oral signs, but this is where dentists get into a little trouble in terms of trying to get into the dental sleep medicine world and not succeeding. There are many other bubbles, and so my particular practice, South Louisiana Dental Sleep Medicine, is in the middle, like the little hub. It's got 80% of patients with sleep apnea undiagnosed. The little fade away in the percent is because our goal is to try and put a dent in that 80% number. But there are many other bubbles regarding, not so much the one on the left about training dentists, not so much that bubble, but all these other bubbles have to be accounted for to be successful and not do just one device here, one another from here, to really have a successful, thriving dental sleep medicine practice and business. And to be able to do all these other bubbles, which have no bearing on your prior dental experience or your staff's dental experience, is difficult, especially when we are on this hamster wheel, right? Because our knowledge and experience is only going to be good for that oral appliance therapy component. All these other bubbles have nothing to do with dentistry. So it's a challenge. And so, it's no wonder nearly 9 out of 10 dentists, I was in that number, right? Within the first 12 months, will give up at dental sleep medicine because there are so many issues that come up. These are 15 reasons we teach in our course. There's many other reasons, but, so it's not a surprise because we're trying to get into the sleep medicine world with a dental hat, which is only 10% of the sleep medicine world or dental sleep medicine world, right? So something that we do is a little bit different in our training. One, we focus very much on small groups. So we usually max out at 5 dentists and their staff per training session because I've been to many groups where, and it's good training, but there's 20, 50, 100 dentists in a room from all different states, all different laws, all different guidelines. Some are associates, some are partners, some are sole owners, some are DSO based. They all have different nuances that have to be addressed that can only be addressed in small groups. So we pride ourselves on limited number of dentists at a time, working closely, kind of customizing everything to those dentists. The other thing that we've developed just recently, hasn't been very long at all yet, but less than a year, we started devising something that says, when I started this in 2007, in terms of my experience into the dental sleep medicine world, which is a story I'll share another day. Knowing how to screen patients, hygienists can do it. The sleep testing can be done readily, very easily nowadays, and focusing on the oral appliance therapy. If that's all there was to it, that's great. But there's these other bubbles. And so what we decided to do is say, well, on top of teaching dentists, for what amounts to like $6 an hour, if you were to hire a full-time employee, hypothetically, for $6 an hour, we basically have already been successful in doing this. We, in essence, instead of telling you what to do, which you'll know what to do, but we basically do it for the dentist. So we do it on all aspects where the dentist truly only has to worry about screening through hygiene, getting the patient some sleep testing, several avenues to do that, and focus on the oral appliance, where the dental knowledge existing already comes into play. You don't have to worry about, we work it where dentists don't have to worry about all these other bubbles to be taken care of because we're doing it. But to the physicians, to the patients, to the outside world, you can put your own practice logo on top of our mentorship logo because to them, it's going to be as if you're doing it yourself. So we found this to be a very, maybe a more effective way to put a dent into that 9 out of 10 dentists who do not succeed at this because we just as dentists do not have time. Had I had this available in 2007, I would be where I am now, probably 10 years ago. So it took a lot of blood, sweat, tears, heartache, and everything else to get to where we are now. And I would never go back. I love where we are now. And so we've got this process here where dentists can get training and they can get a mentorship, basically apply and see if you're accepted into the mentorship program, basically have the bulk of the work done for you or for them. And so it's find it to be very easy for dentists, and the staff loves it because I think everyone on board listening tonight would probably agree that their staff probably feels like they're already maxed out in what they got to do. They probably don't want to add more to their repertoire, especially if what they're adding has nothing to do with what they've learned in the past, right? So it makes it a bit of a challenge. So anyway, so we offer this behind the scenes support. This is of course after training. And back to the question of where do I start? Well, start with training. You know, whether you use us or anyone else is fine, but start with training. Don't wait. You know, I always tell doctors, you know, if you want to really begin a life-changing journey that truly is life-changing for not only yourself, but so many other people, really impact their lives, not only the patients that you're treating perhaps directly or screening, but their bed partners, their spouses, relationships. So many things get impacted with this. It's extremely rewarding on so many levels, so many fronts. So feel free to visit our website, dentalsleepmentorshipusa.com. It's got a lot of, you know, tons of information on there for you. And then basically, that is it. This little life ring, whatever you call it, life preserver. The reason that is there, as it was with the prior slides, is, you know, if you see somebody drowning or perhaps drowning or what looks like drowning in the water, most of us would, you know, be reasonable and say, well, let me throw this thing for them and see what happens. You know, it's just something basic. But, you know, throw your patients a lifeline out there. You'd be surprised how many will end up taking it and really change their lives. So that's it for my part for now. And I apologize, it was a little quick.
No, that's okay. We'll give a couple seconds to the questions to come in. I'm just going to take back controls here.
Yep.
And just show this. So thank you, number one, for everyone for attending tonight. And like I said, don't take it from me. The dentist supply company was happy just to simply lend our program to Dr. Cuartas tonight so that he could try to scratch the surface for you. We are getting quite a few questions. This is great. So before we dive in, again, thank you for your attending. You have two special offers for joining us today and giving us your time. One from the dentist supply company. You can visit tdsc.com and you can explore our intraoral scanners and small equipment and get 10% off of those through September 1st. So definitely go check us out there. Our contact information is at the bottom. You can contact our customer care as well as support at tdsc.com. And likewise, it's all about Dr. Cuartas passing on his expertise to you. So he is offering 25% off of tuition. You can use code conference20 on his website. You can also contact Tanya. She's very lovely at the bottom there. Again, this recording, we can share that information in the follow-up. So let me get to the questions here. And if we run out of time for any reason, we will email you with our answer. So we have a question, and Dr. Cuartas, if you want to just respond one-on-one, you can let me know. We can take it offline. But a couple questions about billing. How much do you bill for any of your services? It sounds very broad. So what's your billing strategy?
Yeah, so there's two ways of going about it. For many years, we were strictly fee for service. We've modified it now, and I'll share that, but we've modified it now. We're working with a company where, depending on the state you're in and insurance contracts and all of that, we are doing more of a quote unquote in-network billing structure. So we're doing both. In Louisiana, the cash pay option for patients is about $2,400. For the, that's fabrication of the oral device and all the follow-up appointments. There's a very specific treatment protocol that we have for our patients, including some follow-up testing and some different things that go along. So it's like an all-inclusive package. So that is our cash pay. When we're doing in-network billing, the reimbursements with some of the contracts that we have access to through this group that we work with, it can vary from $2,000 upwards to about $6,500. So there's better reimbursement depending again on the state, on the particular insurance plans, depending on which ones they are contracted with, kind of locked in, grandfathered in, so to speak, for better return rates. But typically speaking, we're usually between 2,000 from 2 to 5,000, average about 3,500 a device. That includes again, the follow-up treatment protocol and sleep testing. And for us, the way we do it, we do in essence a forever follow-up. Once we finish our protocol and the doctors, the physician's happy with the results and things have been confirmed that it's all working well and everyone's happy, then we'll see patients on average about 6 months after completion, quote unquote, completion of treatment. But the average patient goes about 3 to 4 months of active treatment, 3, 4, 5 months of active treatment, seeing them once a month initially. And kind of go from there, but I hope that answers the question in terms of fees, more or less what we're looking at.
Yeah, I think so. Why are abfractions a sign of obstructive sleep apnea?
So easy answer there is really anything that we see intraoral signs of bruxism, clenching, grinding, all that good stuff. There's during the apnea events, right? So if someone's clenching severely or bruxing during the day because they have a super stressed out job or something like that, right? That's one thing. That's why it's good to rule out with screening and testing. But as far as nocturnal bruxism and all of that, many times that goes hand in hand with the airway issues, because when there's the apnea events are occurring, there's an entire physiological process that happens that we will get into in training, but there's a moment of a very brief but intense clench moment coming out of that apnea event, right? There's this fight or flight moment, all these different things that are happening. So any signs of bruxism and clenching, especially if the patient's like, no, I don't think I ever do this in the daytime, it to me is a big red flag. So abfractions generally go with, occlusal load, lateral forces, all this kind of stuff. And that's why it's one of those risk factors, because anything that points to bruxism, just like scallop tongue, the wear on the teeth, all those things, tend to point to possible airway issues. Not 100%, but it is a very common indicator. Good question.
Excellent. And I did have a couple about CE, so really quickly I will just say that Dental Sleep Mentorship is providing CE through their AGD PACE license. We will get that to you at least within a week. So keep an eye out for that. Any questions about your CE, you can also contact Tanya at the bottom. So I would just like to put that in there. And Dr. Cuartas, do you bill CDC codes or ADA codes?
So this is, the way we bill is purely under medical billing, right? So there is an ADA code now. I don't use it. The reimbursement, not only is it low, but that's a kind of a long story on that one. I find it's just more straightforward and actually the way we do it simpler, better for the patient too, usually going through the medical billing side. And I don't know how long that ADA code is going to remain. I've heard a lot of conversations about it being eliminated. I don't know. I'm not the expert on the ADA side of it, but yeah, I just build purely through medical. It makes our lives a lot easier, and it's just we're kind of in that routine where it's pretty much every day now, so it's pretty simple. So
yeah,
and that's something that we help with.
Yeah, the regional, what you were saying earlier, is the small group exercises in your program of understanding their local needs.
Yes. We spend a lot of time discussing billing during initial training because it does matter a lot where you are, what part of the country. There's many things that you can't discuss in a 100-member, 100 attendee course. It's kind of tough. So small groups are definitely beneficial.
Sure, awesome. And then got an interesting one for you, Doctor. We see a lots of pedo, and they have quite a few grinders, it sounds like, as young as 2 years old. Do you have any suggestions for pediatric dentists?
Yeah, that is an entirely other presentation, but we just had some patients today in our practice. So children, yeah, certainly, if they're snoring, there's already a problem. Children should not be snoring. The bruxing can be a very big indicator as well. What we find in our practice is a lot of times things may start with possible allergies or things that lend towards mouth breathing, which of course leads to all kinds of skeletal developmental problems, which exacerbate the problem, decrease nasal volume, all this stuff. Mouth breathing, which will increase the tonsil adenoid size, all these different things. And so it's one of those that we don't necessarily do our own testing for, and we certainly don't really treat ourselves because they're growing. So a mouthpiece is not necessarily the treatment of choice, let's say, right? So usually for children, when we see certain issues that point towards a possible airway, which is combined with possibly allergies and mouth breathing, skeletal development, we usually work very closely with allergists, with ENTs, orthodontics, especially if they're treating very young children, specialists, develop, upper and lower arches, create more room for the soft tissue. There's usually a multi-level attack on these children because usually one specialist or one field will not be enough to help them. And that's how we generally, in a nutshell, handle with children. But we are looking for bruxism, snoring, even signs that are ADHD similar, like hyperactivity, doing poorly in school. Those can be signs of airway issues, which lead to, of course, abrupted sleep or disturbed sleep, and leads to learning issues, behavioral issues, things like that. So it's a big problem.
Awesome. Well, I think that looks like that's it for the questions. So I will just say one last time, the sleep questionnaire PDF is available. If you look at your control panel, there's a handouts drop down. If you select that, you can download the PDF there if you would like to consider implementing that into your practice or your hygiene assessment for your new patients. But thank you so much for your time, Dr. Cuartas, and
Sure.
thank you to everyone who attended tonight. Definitely grab a photo of these two codes and check it out. They're only good through September 1st. So appreciate everybody's time tonight.
Yep, thank you, everybody.
Awesome. All right.
Thank you, Maddie.
Yeah, of course. Let's see, we're still